One chronic disease is cancer. And so the reason we do cancer screening is that we know if we can catch a cancer early, the chance of permanent cure is much higher than if we wait and catch it at a later stage. Now, that's not true with all cancers, and there are actually very few screening tests available for cancers. Certain cancers, by the time a nodule forms or something becomes apparent, it's already quite advanced, meaning there has been some metastases. Now, we use stage 1, stage 2, stage 3 for certain types of cancers, but let's say liquid cancers, as some people call it, but leukemias and lymphomas have a different kind of staging. They are staged in that same way, but it doesn't give us as much information. Colon cancer, breast cancer, prostate cancer, lung cancer, those are the classic cancers, which are also big killers, that we do have some screening tests for them. So the question to ask yourself is, why are you doing a specific screening test? Why are you getting that mammogram? Think about that for a second. What might your answer be? The common answer I hear is that because I don't want to die from breast cancer, I don't want to die of breast cancer, right? I don't want to die of prostate cancer. Then the next question is, from the data that we have, from the research that we have, do we know if a particular study, such as a mammogram or a digital rectal exam for prostate, or a PSA, or a colonoscopy, or sigmoidoscopy, or fecal globin test, or FIT test, or any other type of screening test, does that actually decrease your chance of dying from that cancer? So that's one thing. But does it also decrease your all-cause mortality? Let's say that we catch all colon cancers super early and we take them out, but the person actually still dies of some other cause. In that case, the argument is maybe it wasn't really that useful to try to cut out this cancer because the person's probably going to die of some other cancer. Prostate cancer is a classic example where if you remove the cancer, because it happens in older men generally, chances are they're going to die of something else. And if you didn't treat it, chances are that cancer would progress rather slowly. Most prostate cancers progress very slowly, and the person would die of something else. Which is why the PSA has come into question, and there is data you can read up on it. So usually an organization like the USPSTF will make recommendations, and other places you can read up on it is Cochrane Review, and WHO, CDC will have some content on that, and the NHS and Australia and Canada, their healthcare system will also have some guidelines on how to use a PSA for prostate cancer screening. But I know for myself, if I do a PSA and it's elevated, and the next step probably will be a digital rectal exam maybe, or a rectal ultrasound or rectal MRI. And if that's positive, well, should I take that cancer out? Because we don't really know what kind of cancer that will be. Will it be the super rapid cancer that's going to kill me, or will it be the super slow cancer that's just going to grow forever and not going to do anything to me? Those are unfortunately the questions that we haven't fully teased out, especially with cancer screening being a little bit more common now than it used to be just a few decades ago. And unfortunately, the more effective cancer screening becomes by definition, the less likely it is that you're going to be able to prevent somebody from dying. Now, this is a little bit more of a complicated topic, and I'm not going to dive into it. But I know that if I do a cancer screening test, I want my all-cause mortality to go down, not just my cancer death. Because what's the point of getting a mammogram done and I just end up dying of a heart attack 2 years later, and I do all the surgery and chemo and radiation and all that other stuff, and maybe some of the side effects from the treatment are going to make my overall lifespan shorter. So from an individual perspective, what matters to me is that I don't die early because of this diagnosis and that I treat it. So that's probably one of the reasons we, for example, will treat people with antibiotics for certain conditions, right? I prescribe antibiotics because I know that if I leave this alone, this infection alone, it's just going to get a lot worse. Either it's going to cause morbidity or mortality, and I'm trying to decrease both of those. But we don't treat a urinary tract infection if somebody's like on a deathbed, because they're probably going to die of something else. So actually treating that UTI with an antibiotic might prolong their life in an uncomfortable way. So that's not something we want to do. And that's the beauty of medicine. It is an art. It is a science. It is an art. But there's two things. On one side, you have population health. On this side, you have medicine. Western medicine, is an individualized approach to the person. So Mohammed Ashori, what are your risk factors? What are your lifestyle goals? If you had rectal cancer, would you want radiation? Would you want brachytherapy? Would you want, chemo? Which means you're going to have a lot of problems down there afterwards. Do you want that, right? We don't get to have those discussions many times, unfortunately, because our healthcare system is fast-paced. So that's an individual approach. Do you want to do the screening if it means that you could decrease your risk of this or this because you have a family history of this type of cancer? On a population level, the discussion is very different. The USPSTF is going to recommend mammography. They're going to recommend lung cancer screening with low-dose CT. They're going to recommend PSA, or, again, that's up for debate. And you have to choose. Do you want to follow general guidelines, or do you want to follow a guideline that is a little bit more specific to you? And that's the beauty of medicine, I think, that I can individualize it to my patient. So I hope I gave you a sense. I hope I give you kind of that nuanced feel to the difference of cancer screening. Why should we do it? Why should we not do it? All-cause mortality, cancer mortality, and, mortality in general from any other cause. Well, I guess that's all-cause mortality. What should we do? Should we screen the person? Should we not screen the person? Would the screening have other consequences? Colonoscopy, you can get a tear. PSA could just be from normal elevated prostate or a prostate infection. Now all of a sudden somebody finds a nodule. And don't think that a biopsy is all that accurate either. Unfortunately, there are cases, many cases, where a biopsy is done and the pathologist will read it as cancer. And then when this is analyzed, other pathologists weigh in, actually wasn't cancer. It's quite common with even breast cancer. It's very common with melanoma, incredibly common. So just the biopsy alone is a risk to your health. But I'm not saying you shouldn't do it. I'm saying an individualized approach makes the most sense to me. I hope that's helpful. Check me out at Digital Nomad Health. Please subscribe to this channel if you're interested in getting more content like this. And also, your input's really valuable to me as this channel grows. I would love to find out what you guys would like to hear more about, what's more useful to you, so that I can avoid the stuff that's useless to you. Take care.